I maybe should have said that before we started. We're going to try to keep each presenter at or below 10 minutes. If we can move on to Kendra Martello, Deputy Vice President, Strategic Operations for State Policy for Pharma. Welcome and good afternoon.
Thank you. Good afternoon, Mr. Chair, Madam Vice Chair, and distinguished members of the committee. My name is Kendra Martello, and I'm here today on behalf of the Pharmaceutical Research and Manufacturers of America, or PhRMA, which is a trade association representing more than 30 of the leading research-based biopharmaceutical manufacturers. I'm pleased to appear before you today to provide our perspectives on making the healthcare system affordable and to describe the significant role that prescription drugs play in our healthcare system, most importantly by providing new treatments to patients and hope. This is an important topic, and I appreciate the opportunity to provide our perspective. The cost pressures that Medi-Cal, CalPERS, and other healthcare programs are facing are very real, and they need to be addressed. As we consider this complex issue, it's critical that we look at healthcare costs holistically and recognize the role that medicines play in controlling overall healthcare costs. We must also continue to recognize the need for research into new treatments to help address the great unmet medical needs in all populations across this country and in this state. Because ultimately, it's the cost of disease and the cost to treat those unmet medical needs that will have significant negative consequences for patients and could truly bankrupt our healthcare system in the long run. Finally, we need a system that does not shift so much of the burden of paying for healthcare services onto the patient, and that doesn't inject unnecessary access restrictions between a patient and their medicine. This debate is occurring at a time when prescription drug costs have grown at historically low rates and more slowly than total overall healthcare spending. In fact, the federal government recently lowered its projections for future prescription drug spending and estimates that drug spending will grow at the same rate as overall healthcare costs over the next decade. Today, prescription drugs account for only approximately 10% of healthcare costs. This amount of spending on prescription drugs has remained constant, going all the way back to 1960. And federal projections are that drug spending will remain at this level through 2023. Thus, to put it in context, spending on prescription medicines has been and is projected to continue to be approximately 10% of overall healthcare costs. In Medicaid, prescription drugs are an even smaller part of the story. Drugs represent approximately 4% of total Medicaid spending. And while we understand that there may be concerns about the cost of particular new medicines coming to market, any discussion of prescription drug costs must also take into account the great value that innovative medicines bring to patients, to society, and to our healthcare system as a whole. While overall drug spending has remained steady, at the same time over the last decade, more than 400 new medicines have become available to patients. This includes medicines to tackle some of our most complex and debilitating diseases. And it's important to remember that progress is made incrementally in many cases, and the true value of a medicine may not be realized for years to come. The advances we've made in developing innovative medicines has changed the course of disease for many patients. For example, the death rate from HIV and AIDS is down 83%. In fact, a person infected with HIV today can be expected to live into their 70s, which is the same life expectancy as you or I. When AIDS was first discovered, the Army was spending $500,000 to treat AIDS patients in its care. With the advent of medicines, a previously fatal disease is now a manageable condition. And even with large increases in the number of persons living with HIV, total costs have remained largely the same over time. In other words, we're treating many more patients for 4 times as long at roughly the same cost. Medicines have led to great advancements in other disease areas as well. The 5-year survival rate for cancer has climbed to nearly 70% since the mid-1970s. And that's notable since today is World Cancer Day. Over the last decade, death rates from cardiovascular disease have fallen nearly 40%. These types of advances mean patients can get back to living their lives, being active in their workplaces and in their communities much sooner, and that benefits us all. So how is this possible? That we can continue to develop innovative medicines and yet have prescription drugs still remain only approximately 10% of healthcare spending. It's possible because of the pharmaceutical life cycle. First, unlike any other part of the healthcare system, with prescription drugs, costs come down rapidly. When a new drug is approved, it often has competition from another brand medicine in a very short time. We see that currently in the hepatitis C market, and we saw that with HIV and AIDS drugs in the 90s. Second, after about 11 to 12 years, innovative medicines lose their patents and face competition from lower-cost generics. In fact, nearly 90% of all prescriptions today are filled with generic drugs. The resulting impact of these factors on prescription drug costs is dramatic. For example, in Medicare, we saw the daily cost of therapy in the 10 most commonly used classes of medicines fall from $1.50 per day in 2006 to $1 a day in 2011, and is projected to fall to below 50 cents a day by 2017. You simply don't see costs decline like that anywhere else in our healthcare system. Yet, what we're seeing is that a great proportion of the cost of these innovative life-saving medicines are being passed on to patients, more so than for any other healthcare service. This could cause patients to go off their medicine, which could cause their health condition to worsen and lead to greater costs down the road. The fact is, patients who stay on their medicines have better health outcomes and make less use of urgent care and inpatient hospital services than those who are not adherent to their medicines. Bringing new medicines to patients isn't easy. In fact, the drug development process is costly and uncertain, and the vast majority of compounds that enter clinical trials fail. In fact, the failure rate of drug candidates in clinical trials is nearly 95%. Yet, pharma member companies have invested more than $550 billion in researching and developing new medicines for patients since 2000. In fact, in California alone, there are currently more than 3,100 active clinical trials. So while we've made great progress, much more needs to be done. We need treatments for Parkinson's, MS, and Alzheimer's, just to name a few. New medicines that would delay the onset of Alzheimer's could reduce Medicare and Medicaid spending by more than $100 billion a year by 2030. In contrast, we do nothing to address this health need, then our healthcare spending will increase, for Alzheimer's alone, up to $1 trillion. So to foster continued medical progress, we need a system that promotes innovation and rewards it, and allows the ability to recoup investment in research and development, not just for the medicines that make it to market, but for the vast majority that don't. In order to keep people healthy and to avoid more costly healthcare interventions later, we need a system that doesn't put arbitrary access restrictions between a patient, their doctor, and a medicine. Getting the right medicine to the right patient at the right time will help us achieve the desired clinical outcomes we know are possible, and also help reduce healthcare expenditures in other areas. Thank you very much.
Thank you very much. We'll move on to the final presenter for this section, Dr. Jeffrey Joyce, Associate Professor, Clinical Pharmacy and Pharmaceutical Economics and Policy at USC. Welcome.
Thanks for having me. And Senator, when you mentioned earlier, I think we need to put this, sorry about that. I think we need to put this into a broader perspective to start. And you mentioned the growth in healthcare spending. It's not a new problem. It's been 6 decades where we spend considerably more than the growth of our economy. And spending in and of itself is not necessarily a bad thing. We spend a lot more on Apple products, we spend a lot more on semiconductors, and we think that's beneficial to society. The issue with healthcare is we think there is some inefficiency and waste in the system. But part of the growth in spending has been we're a wealthier country, so we spend more on everything over time. Aging a demographic population, as we age, we spend more on healthcare. Then there's the growth in insurance. Medicare, Medicaid, and private insurance become more generous, which has made healthcare more affordable. And then the other half, roughly, is we think the growth in technology. And I think that's what I'm going to talk about briefly here is this sort of dilemma between access to healthcare and technology and the effects of innovation. I think in the short run, we all want unfettered access to the latest technologies. And I think high prices obviously restrict access to those goods. But in the long run, we also want firms and innovators to develop new treatments, and they need financial incentives to do that. So we have this trade-off of how do we ensure access to treatments, and how do we not discourage or actually encourage innovation. And from an economics perspective, we tend to take a much broader view of what is the value. And I think the inefficiency in our healthcare system is that we largely pay for doing stuff as opposed to value. And I think the panelists before me talked about value. That I think is, from an economics perspective, how we view this. HIV is a good example. It was one of the most, obviously, devastating global diseases. New technologies emerged, new drug treatments in the mid-90s, and it transformed the disease. And if you quantify the life savings, the life years gained as a result of these drug therapies, they more than pay for themselves. Matter of fact, our colleagues did research and said only about 7% of the value of those drugs went to the innovator. The other 93%, if you quantify the life values, went to the patients who were HIV positive. So again, broadly speaking, yes, we spent over $60 billion on HIV medications, But if we monetize the gains in life expectancy, they're over $1 trillion. And so again, we do want to encourage the innovation of those types of products. They're life-saving, they're beneficial from a societal perspective, but they're not cheap. Very few things, if any, save money. Many things in healthcare are cost-effective and we think worth doing from a societal perspective. Cancer has become another issue as well. I think where we believe is the life gains are modest at times. There may be quality of life decrements for some cancer treatments. And is it worth it? What have we gotten? Well, from 1988 to I think about 2000, we gained about 4 years in life expectancy across all cancers. So the gains in life expectancy have been enormous. And there are some celebrated cases like Gleevec, which one of the other panelists mentioned, for leukemia. Transformed it from a very terminal disease where life expectancy in 5 years was minimal to a chronic illness. And again, same thing, if you do the calculations of the life years saved, the value to society of that product relative to what the profit was to the firm that innovated, the vast majority of the value went to society. And so we want to encourage those types of things. And I think the lessons and the take-home lessons from both HIV and cancer, this is going to come up in Hep C as well, is for innovators with breakthrough products, okay, most of the value went to society and not to the innovator, okay? And yet it's a long, risky process developing drugs. Again, not all drugs are value-driven, but for many of them, we want to reward innovation, and society generally benefits from that. Which brings me quickly to Hep C and Sovaldi, because we've had a lot of talk about it. And it's a disease, obviously, that it's unusual. I think, as Greg mentioned, it's rare that we have a drug that actually eliminates and potentially eliminates a disease. That in and of itself, we want to encourage. For example, if we had a drug that eliminated diabetes, it would cost a lot of money. Would we want that as a society? Absolutely. And again, what we are going to see is this huge cohort of costs downstream if we don't address Hep C. And I have colleagues who have modeled different scenarios because, as Greg mentioned, it's extremely expensive if we were to treat the whole Hep C population today. How can we do this more cost effectively over a longer period of time? But unambiguously, the value to society is much, much greater than the cost of these medications, let alone the offsetting medical costs associated with them. So again, I think that the general rule, I think from a health economist perspective, is we need to pay and reward value. And we need to say, how do we create that efficiency in the healthcare system? And I think the Affordable Care Act is moving us in that direction. So we're getting away, I think it was occurring prior to the ACA, I think it's accelerated it, of how do you treat a population? How do you treat them more effectively as opposed to we're going to pay you for doing more things? And in that type of environment, I think we will see health plans, providers, hospitals that have to treat a population will make value decisions. Is this treatment beneficial? Is this MRI worth it relative to an X-ray? And is this drug truly of value? And I do think the one thing I think economists really focus on is you do not want to stifle innovation. There are other ways to improve access to care for these products, but we have gained enormously in life expectancy and quality of life by allowing development of these products. And again, it's not just the US market. We develop this drug, it affects people worldwide. And sometimes we do get caught up in, yes, we do subsidize the rest of the world in some respects, but the value to the community at large is great. I'll stop there.
Thank you very much. Is there any questions from any of the members? Senator Pan, and then we'll go to Vice Chair.
Sure. Well, first of all, this is a fascinating discussion. I have to say is when I was young, unfortunately, one of my relatives died of hepatitis C, and there was no cure then. So it's amazing that we have one now. And I think we need to keep that in mind because there are people who couldn't get treatment before they died. But at the same time, I think people are concerned about, right? But one thing I did want to follow up, since I asked the previous panel, and we have someone from pharma here, what do you think is going on with the generic drugs situation when we're talking about medications? I know this panel focused mostly on specialty, but in terms of, people talk about doxycycline and some of these other medications. What's going on? Why are those rates going up? Why aren't other people entering the market when the prices are going up? What's the situation going on for essentially non-specialty drugs and drugs that, and so forth?
Good. I recently wrote an article about this, and we're doing some research on it. The generic drug industry is very different from the branded industry, right? It's generally much more competitive. If you look over the last 20 or 30 years, generic drug prices have stayed flat or even fallen in many cases in aggregate. More recently, we have seen some large increases, not across the board, but some egregious price increases. And it's a combination of factors. Collusion is very hard to prove. When you mentioned, is there FTC and Attorney General interest? Yes, there is on this, okay? I think there has been consolidation in the industry. Part of that was driven by margins got very low. It was almost similar to the airline industry and the cable industry. When you deregulated, competition came in, prices fell dramatically. But over time, as margins got small, you saw consolidation, you saw outsourcing and moving production overseas. Most generic drugs are produced overseas, which affects the supply chain dramatically. We definitely have fewer players in some drug classes. And the general rule in economics is you need 3 to 5 competitors to have a vibrant market. And clearly, in some cases, we've fallen below that. And sometimes you have the branded manufacturer buying a generic maker, so they have both the branded and the generic product, and that creates conflict of interest. So clearly, in some areas, we've had price gouging as a result. And again, there's no great solution. I proposed one in a paper. I said, generally, we don't worry about the effects of innovation for these products, right? These are 20, 30, 40-year-old products. But we do want to make sure there's an adequate incentive for firms to stay in the market and produce. So you might want to set price floors, right? We're going to guarantee some minimum price because, again, at a $4 generic at Walmart, there's not a lot of profit margin there. And you see firms pulling out of the market. Set some price floor like we do in agriculture, but at the same time, set price ceilings. You cannot raise prices more than 50%, for example, within a year without justification on why you're doing that. It's a complicated, the supply issues are complicated, but that industry is very different from the branded one in the sense that they are not innovating. And we want to promote competition in that marketplace.
And I think I also mentioned, there's the two ends. There's the price, and then there's the supply problem, where we found out there were some examples of medications which people desperately needed, but there was the supplier disappeared. And there was
Yes, and one of that is they've outsourced a lot of production overseas. So the vast majority of active ingredients or products in the generic market are produced overseas. There have been plant closures. And when someone mentioned a very good question, why don't we see entry into the marketplace? And there's a backlog, an enormous backlog at the FDA for generic approvals. So getting into the industry, if you see an opportunity getting in, it's backlogged. They've got over 900 molecules waiting to get approved. Sorry.
Thank you. Madam Chair? Madam Vice Chair?
Thank you, Mr. Chairman. Mr. Alton, I have a question since you talked a lot about, the comparison between someone on hepatitis C, their life without Sovaldi, without that cure immediately, which is only 8 to 10 weeks versus a lifetime. What is the differences in cost of a patient living on hepatitis C and not being able to get that cure in terms of cost versus the 8, 10 weeks that you've talked about? Because I think it's important for us to understand or see those numbers to understand what you're trying to state.
Is this on? Okay. So there's been a lot of research done in this area trying to predict what the cost is. I think what you're asking is what does it cost not to treat hepatitis
Yes.
C? It ranges, it really depends on where you start with a particular patient and what sort of level, we call it fibrosis they're in. And that's really how sick they are, how much the hepatitis C has caused problems within the liver. There's some of the studies that we've shown, this is based on a database from a hospital system, shows for the healthiest patients who have hepatitis C, their annual costs are roughly $20,000 a year. Up to the sickest patients, it's over $100,000 per year. And what we have, as I mentioned before, we have an aging baby boomer population who probably contracted hepatitis C in the 70s, maybe a little bit sooner than that. So they are actually advancing quite quickly. So what the guidelines are suggesting, and this comes from the Liver Disease Society of America, is we want to treat the people who are sort of in the middle to the sickest range. We call that F2. And so it's a specific population of F2 who have other complications, and then the sicker patients, F3 and F4. I would say it's not the cirrhotic patients necessarily, but they are the more advanced liver disease, because that's where we're going to get the most immediate benefit. But I hope that somewhat answers your question.
It does, thank you, because, earlier I did mention about preventive care. To me, this is almost like preventive care. It costs us a little more now, but yet the lifetime, we actually should look at someone's life's worth.
Correct.
And so that's why, I want to get that clarification, is because I think that, I'm not saying that's justifiable with the cost that we're seeing right now, but I think we should also look in a global perspective as what is one's life's worth? And what Dr. Pan mentioned, he has, family members who dealt with this, who could have now, 20 years ago, now would have still been alive. And I think we should look at it more global. My question for Dr. Joyce is, you talked about, we shouldn't curb or, stop innovation. I hope that this hearing doesn't in any way suggest that we are, because we shouldn't. We are a country that is trying to make sure that science and math comes back to our children and that we can be much more innovative. We were one of the leading country of innovation of everything. We have now gone away from it, and even generic drugs, we are shipping it off, and there's many arguments to it, whether it's doing business wherever it is, United States or even California. I want to make sure that, at least in my perspective, that this hearing is to understand the deep costs and how we can come to a conclusion, or at least to some kind of way that would work for quality care for patient. At the end of the day, is to cure them for their life and for their family. Not in any way of stopping that between the patient, the doctors, and the innovation that can cure that.
No, I agree. We don't, and I didn't mean to imply that at all. And we don't want unfettered access to all technologies. We can't afford that. We do have to make intelligent decisions. And I think, again, basing it on paying for value as opposed to just paying to do stuff is really what we have to move towards. And just briefly, colleagues at RAND did a study on waste in the healthcare system. It was very, very hard to find a device, a procedure, a drug that didn't benefit some group of patients. The problem we tend to have is we expand who gets that drug, that device, that procedure to a population that may be too broad where the benefits are relatively modest. So it's not restricting the technology. We want to foster that development, but being smart about who gets access to it.
Yeah, no, absolutely. I mean, because specialty drugs to me is like specialty doctors. They're very rare and very limited. I always talked about when I was in, now I also have Los Angeles County, but being in Orange County, back then as county supervisor, I always say, I'd rather have more than one heart transplant, cardiologist for 1,000 patient versus zero, or one for all of Orange County, 3.2 million people. So we have to work on how to build and foster innovations and to provide more of these medication out to the public domain so that they have access to it, quality access, plus the cost effectively. So,
No, and I often speak to groups of physicians, and I'll ask, would you rather have 1960 healthcare and 1960 prices, or today's healthcare and today's prices? And unambiguously, they want today's access to today's technology.
well, absolutely, because we can now cure hepatitis C. Thank you.
A couple questions. I'd like to first start off with a comment that Dr. Joyce made with regard to comparing spending. And you said we spend more money on Apple products than we do on innovation.
Oh, no.
I thought that's what I heard you
Sorry.
say.
No, I'm saying, if I had shown you growth in spending on semiconductors and growth over the past 50 years and on an Apple products over the last 20, just because we spend more doesn't necessarily mean that's bad. We believe those are individuals making decisions that, hey, I think this product is worth my money relative to another. It's in healthcare, we think, so high spending necessarily is bad, and that's not necessarily the case.
But I mean, using still that analogy, there still is a big difference. We're not mandating that every single person in this country purchase an Apple product. What we are mandating through the Affordable Care Act, which I fully support, that everyone purchases health insurance. Now, it is incumbent upon government to make sure that they're getting a product that they can afford, because that's what the public is asking of us as elected officials. So I'm going to be looking at it through that lens. Now, don't get me wrong. I am not at all saying you should not have innovation. I truly believe that we should have innovation. I value the fact that pharma, what they do is they bring to bear to the market incredible drugs that save lives and help us extend our lives. We've used AIDS as an example, and I truly, truly appreciate that. And I also appreciate the fact that pharmacy or pharma has kept their drugs at around 10%. I believe the national average is between 9 and 10, and it's due to the fact that the pharmaceutical life cycle, but also that your quote was innovative medical medicine loses their patents after a certain period of time. So I would hope that that would continue to evolve into, as we continue our healthcare discussion. I also wanted to just make a couple comments about some of the statements that Mr. Alton made with regard to the pricing of your particular product. And I'm going to eventually get to that because obviously there's a lot of concern, and that concern is not coming from the legislature. That concern is coming from the public, and it's coming from those who buy and sell that product. And ultimately, that's still the state of California, because as you saw through this last budget cycle, the governor put $300 million in just for your product. So you had mentioned that the way you price it is not for the cost of the development, which that's kind of counter what I've heard to other pharmaceutical manufacturers, because there's a certain cost of development. You talked about how it's made, how you made an investment, the unmet medical need, and how many patients suffer, and more importantly, what you do is you look at similar therapies. Which is fine, but I still need to figure out how you come up with a unit price or how you decide to do the cost of doing business. But when you talked about pricing of Sovaldi, obviously you use a bunch of catchphrases, which we mentioned, but what I still heard is what the market will bear. And I am a big believer in capitalism, as I mentioned before, but you aren't operating in a normal market. You have a government-issued patent. You have an artificial demand because people will die if they don't get your product. And in light of this, does your company believe that you have a moral obligation to price your products at a level that is accessible? So that's my question to you.
So to answer your question, your last question, I'm not sure I'd characterize it as a moral obligation. I would say that we feel we do price our products at a level that is affordable to the healthcare system, particularly when you actually factor in the value and the quality of what we're providing to that healthcare system and the results of using that medical intervention.
But if that's the case, then why is there so much concern about the immediate upfront cost? I understand that in the long term, you're going to save, overall healthcare costs. But if we compare this to AIDS, was there a similar type of medication that was the prices were over the top at the point, and they leveled out? So, I'm responding to a lot of concerns that are from my constituents, whether it be the public, whether it be, the various entities. But more important, I'm responding to the fact that this is going to be a huge cost to the general fund in the state of California when we have limited amount of dollars that are going to go into the healthcare system. Those limited amount of dollars are going to be provider rates that the vice chair and I both agree need to increase. But if we can't do these type of things, if we're going to continue to have, and I would hope that this doesn't increase the cost more than the traditional 10% that pharma has. So, I'm just, these are just some of my concerns and some of the questions that I have for you. But is there any other comments or questions? I know Mr. Cooley's here. He's came from the assembly. I asked him to come and sit, but I wasn't sure if you had any comments you'd like to make.
Well, I'll just jump out and make some observations more. I just thank you for the hearing. I think it's obviously very topical. We had a rate regulation measure affecting healthcare on the fall ballot, which went down, obviously. The subject matter of this hearing interests me because I previously served in the State Assembly as chief counsel with at least one colleague I've seen here in the room sitting back there wearing a pink shirt. When Prop 103, the precursor to Prop 45, was on the ballot in California. And I just want to remark on sort of a dynamic that I saw the legislature go through in that era, which I relate to this subject. In 1988, Prop 103 passed. It was a rate regulation regime. Within 2 weeks, the New York Times opined upon the passage of that, a rate regulation system, that it was no fix for the costs of a state-mandated product in the state of California, which at that time was auto insurance, which had risen 150% in cost in just 9 years. And it precipitated a need by the legislature to kind of look around and say, there is something that is mandated upon our citizens, is rising rapidly in cost. In that case, we actually had a new rate regime that was in sort of a gun at everyone's head. You got to figure out how to deal with costs. Since it itself did not include the costs, it prompted a great reexamination by a lot of the parties that had some piece of that cost system, in this case of auto insurance. It led to a whole enumeration of statutory changes, other sorts of things, as different efforts were made to bring down the cost of auto insurance. And what is notable, you know, at the start of that conversation, everyone was sort of each other's throats. You get them all sitting around the table, Mr. Chair, and everyone felt extremely uncomfortable because they all sort of felt the target was on them as to where you'd cut the cost in the system. Out of that process, through the work of the legislature and in both houses, a great many enactments were passed. And you can actually look back at the cost claim data for that era, and you see that over the 1980s, the national cost line and the California line diverged. And over the course of the next dozen years, those lines came back into alignment. So I think this is certainly what we saw then. Every person's way is right in their own eyes. They sort of understand how they do it. But there is this underlying public policy issue which you raised, that this is a mandated product. Access to it is extremely important. The state of California, the cost system of our prisons, Medi-Cal, all implicated in this conversation, and sustainability is implicated. So I think, trying to look at how the costs are structured and what is fair and what is sustainable, and to the extent that there are some of the pricing stuff, I also heard that there's some factors that go into how they arrive at the cost that maybe are worth further conversation, as you noted just a moment ago. So that's the extent of my comments. That's actually why I came to the hearing. It's like I've participated in this sort of conversation before, and I was very interested to see what your committee was doing. I just thank you for the courtesy to be here.
Thank you. I'd like to take this opportunity to thank you for being presenters. We're going to move on to item number 4, provider perspective. We're going to have 2 panelists up here. Ann McLeod, Senior Vice President, Health Policy and Innovation, California Hospital Association. Dr. Stephan Lockhart, Vice President, Chief Medical Officer, Sen Health. You can come up and